Hello everyone. I am Dr. Abhishek Vaish, consultant orthopedic surgeon at Indraprastha Apollo Hospital. Uh, I'm delighted to present a lecture on basics in orthopedic radiology. We will talk about a lot of MSK modalities, but mainly our main focus will be on X-rays, ultrasound, and MRI of lumbar spine, shoulder, and knee. We can take the questions at the end, and I would be happy to, answer any questions which you may have, and you may feel free to ask any questions at the end of the lecture regarding to this lecture or in general as well. So we will talk about basic X-ray reading, case discussion. We will talk about 10 interesting cases, and we will see how imaging helps us to plan those cases and plan manage treatments. We will also talk about other modalities in musculoskeletal radiology. We will then at the end talk about basics of reading knee MRI, shoulder MRI, and lumbar spine MRI. So when you see an X-ray, when you get a patient, you will have an X-ray. How to go about it? The X-ray reading should be very systematic, and you should start with the basic ABCs. So A is for adequacy of the X-ray. Is the X-ray taken well? Is the contrast okay? Is it a digital X-ray or it's a normal X-ray where they develop a film? You check the alignment of the bones and is the joint in place. B is for bones. Then come to the bone, look from top to bottom or bottom to top, look at the epiphysis, metaphysis, diaphysis, and see if there is any abnormality in the bone structure. C stands for cartilage. So, though you do not see cartilage on X ray, but you can have a fair idea about the cartilage when you see wear and tear of the joint, like reduced joint space, which can give you an idea that the cartilage may be wearing out and you may need to do additional imaging like MRI scan or a cartilage sequencing to know more about the cartilage. S stands for soft tissues. Though MRI is a gold standard to look at soft tissues, but you can have a fair idea about the soft tissues when you do an X-ray. I will share how you can look at the X-ray and comment about the soft tissues in a short while. So always do this ABC approach to see the X-rays and evaluate them systematically every time you see a patient. All X-rays should have adequate number of views. So you should have at least minimum of two views, that is AP view, anteroposterior view, and a lateral view. If you are dealing with a non-union, a malunion, or a bone which is oblique or funnishly shaped, like if you, for example, take example of pelvis, so you may need special views like obturator views, iliac views to comment more about the fracture pattern. And it is gold standard to uh, get an X-ray of a joint above and below because there are many type of fractures like Masonet's fracture where if there is a fracture at the distal end, there is definitely a fracture on the proximal end as well. So you should always have this habit of getting an X-ray of the joint above and a joint below. And all X-rays should have adequate penetration. So what is adequate penetration? An under-penetrated film is too white, so it is diffusely opaque. This is not a good image. Again, an over-penetrated film is very, very translucent, so it appears too black. And secondly, it can give you a false positive image like of osteoporosis in a patient. So you should not rely on such X-rays, and you should order adequate penetration X-rays. So I discussed before the rule of two. Always, always, always order two views at least for a part which you are interested in, that is most commonly a anteroposterior and a lateral view. Look at the two joints, one joint above and one joint below. Two occasions repeat the x-rays. For example, you are dealing with a distal radius fracture which you have reduced and put in a plaster. So you should order for a pre-reduction x-ray and a post-reduction x-ray, and also do an x-ray after maybe a week, 10 days, to see if your reduction is getting maintained or it is getting displaced. And sometimes, in cases of deformities, we may need x-rays of two limbs to compare how much the deformity is. Maybe the patient inherently has a valgus or a varus deformity, and that is not the cause of the problem. But if you just do one x-ray, you may feel that the patient is having a problem because of this. So always do two limbs to compare when in doubt. So this image precisely tells us why we need images, why we need two views. So if you just rely on one view, you may come up with a false image or false interpretation of your result. So it is very, very important to have two views. I am focusing and emphasizing on this fact again and again. So as I told you, you cannot comment about the cartilage in a X-ray, but definitely you can see that there is joint space narrowing on the bones. So you can comment that maybe the cartilage is worn out, and you can do an MRI to find out more about the cartilage damage in these cases. So you can see this is the X-ray of an elbow, where you can see this is a lateral view. If you trace the bone here, you can see that there is some shadow anteriorly as well as posteriorly. This is not normal. So there is some bleeding here, and it shows us there, and this also emphasizes that there is anterior fat pad sign which is lifted off, and there is some posterior fat pad which is lifted off. So this may indicate sort of injury where you need another view, and maybe MRI or a CT scan to confirm a fracture if it is not uh, bluntly visible on a X-ray. So before you can make a diagnosis, before you can find out more about the pathology, you should know the anatomy. You should know what is normal. If you don't know the normal, then how will you focus on what is abnormal? So this is a plain X-ray anteroposterior view of a knee and a lateral view of the knee joint, where you see the distal end of the femur, the proximal end of the tibia, the fibula, and you can also outline the patella in the AP view. Patella is better viewed on a lateral view and a special view called skyline view, where you can see the positioning of the patella. If it is going up, it is called patella alta. If it is going down, it is called patella baja. Then the position of the femur, the translation of the tibia, and the position of the fibula with respect to the tibia. So all these give us very important signs, which if you read the X-ray well, you can catch even without doing very high-end radiology imaging. Again, this is a normal X-ray of a shoulder joint, left shoulder joint, AP view, where you should be able to see the full profile of the clavicle. This is the distal clavicle, which is getting articulated with the acromion process. This is the coracoid, glenoid. This is the humeral head with its two tuberosities, lesser tuberosity and the greater tuberosity. You should also have an eye about how much distance is normal between the acromion and the humeral head. This will give you idea if the humeral head is coming up in cases of rotator cuff arthropathy or degenerative arthritis of the shoulder joint. So this is the X-ray of a normal hand. So hand X-rays are very important to read because the pathology is often misdiagnosed or missed if you don't read the X-ray well. So you can see a distal radius and ulna. You should see the position of the ulna with respect to the radius, if it is a positive variance, a normal variance, or a negative variance. Then you should see the carpals. This is the scaphoid bone. This is the lunate, trapezium, trapezoid, triquetral, then the hamate and pisiform. All these things. Then there are five metacarpals, phalanges. So you should see the normal anatomy, and if you know the normal anatomy, you can easily get hold of the pathologies. Again, this is the normal X-ray of a pelvis. This is a pelvis X-ray of the pelvis with both hips antero-posterior view. So this is the ideal X-ray, and you should be able to see all these things. You should be able to see the femoral head on both sides. The trochanter, lesser trochanter should be visible, just visible. If it is too much visible, then the limb positioning is in external rotation, and it's not a good X-ray. You don't see the proper profile of the trochanter. You should be able to see the obturator foramen, the pubic symphysis, the sacroiliac joints, the acetabulum, and the anterior and the posterior column. So you should be able to see everything and a little bit of spine. So this is a normal X-ray of the pelvis, AP view. This is the normal X-ray of a foot, where you can see some part of the distal tibia, then the talus, the head, the body, which is articulating with the calcaneum and in below, and navicular in the front. And then there are the metatarsals and the tarsals and the toes. So this lateral view X-ray is very good to have an idea about the calcaneum fractures, which is also very nicely seen on an axial view. And then it is also important in your practice to see if there is a spur. Calcaneum spur, it will be somewhere here and somewhere here. So it could be either both sides or one side, which gives you an idea about the plantar fasciitis, and you can treat it accordingly without doing any MRI. You should get an idea just by seeing a good lateral X-ray of the foot. So you should also know little bit about what mimics a fracture on an X-ray. So sometimes if you don't know, then you can misdiagnose them as fractures, and the patient might be in a plaster or a splint for unnecessary 3 or 4 weeks, which may delay his activities and also unnecessary cause stiffness around the joint. So what are the fracture mimics? Growth plates. So if it is a child, definitely you can see the good open growth plates, but sometimes in adults there is a scar of growth plates once they are fused. So keep in mind that the scar of fused growth plates can be normal, and it's not necessarily a fracture. Then the second thing which you should keep in mind is apophysis. So apophysis is a normal variant. The third thing is accessory bone. So the most common accessory bone seen is the accessory navicular. Then sometimes there is accessory in the patella. Sometimes there is a bipartite patella, and sometimes because of low vitamin D3 or osteoporosis, there could be these stress lines called Harris lines. Again, these are not fractures, but a deficiency, a metabolic problem. So if you know about these, then you can counsel your patient and then treat them accordingly. Next, coming on to the case-based discussion. This is the first case. This is a case where you can see X-ray of a diaphysis of the femur bone, and you can see these are the cortices. They are quite thick on the top and the bottom, but in the middle, the cortices are thinned out. There is some sort of activity going on here. There is definitely a fracture on both the views, and the bone has thinned out. So this typically looks like a pathological fracture. If you see such sort of fractures, you should try to find out why this fracture has happened and treat that according to what pathology there is, and also treat the fracture accordingly, because this type of fracture is not a traumatic fracture, it is a pathological fracture, which means that it happens with trivial injuries. or the patient may be just walking a little twist and he fractures his bone. So sometimes these fractures give us an idea that there is a pathology, and if we investigate, we can treat them in time and hopefully get a good result for the patient. This is the second case where you can see this is the left hip joint, which is totally arthritic. This is the lower pole of the acetabulum. The acetabulum, the normal acetabulum, which should be there, is marked in a pen. And you can see the femoral head has translated up and posteriorly, and it is somewhat fused with the pelvic bone. So this is secondary osteoarthritis of the hip joint. And when we did the surgery, you can see the femoral head is completely worn out. The white thing is the bone. There is no cartilage on top of the bone because it was abutting with the pelvis. And so this patient was taken up for surgery where we replaced the hip joint, and total hip replacement was done for this patient to achieve full movements and good result. Another case, this is a case of polytrauma. Patient has a fracture of the femoral neck, and also a transverse fracture of the acetabulum. You can see the femur has jutted inside the pelvis, breaking the pelvis and then getting fractures itself. This is a very high velocity injury. Apart from this fracture, you should also keep in mind that because this is a high velocity injury, patient can have soft tissue problems, patient can have problems of the pelvic organs, bladder, blood vessels. So you should approach the patient completely as a whole and not just focus on the fractures. First, optimize the patient according to the ATLS guidelines, and then once the patient is stable enough, then plan your treatment for the fractures. So for this patient, she was a 19-year-old girl who had sustained some bladder injury. First, she was optimized, and then in second stage, she was operated using a proximal femoral nail, and acetabulum was fixed using two plates from two approaches, one from the anterior side and one from the posterior side, to achieve good results. Another case, this is a X-ray of the elbow joint. You already know the normal anatomy of the elbow joint. When you see a lateral view, you can see that this is the radial head, and you can see a fracture line crossing through, and it is a comminuted fracture. You can see one line here and one line here. So, and also there is a coronoid fracture. So such cases, you should always get a CT scan done so that you don't miss out any fracture. And once you do the CT, you can completely know the morphology of the fracture and what plan should be done. So you can see this with the introp image. The radial head was fractured in 4 to 5 pieces, and this was not repairable. So we excised this fractured fragment and we replaced the radial head using a radial head prosthesis. And the benefit and the beauty of this implant is that we can uh, ask the patient to move his hand and rotate the forearm immediately, and to achieve very good results and stability. So another case, this is a 20-year-old boy, or rather a 15-year-old boy, who you can see the bones. They are not normal looking because you already know the normal anatomy. That is why it is important to the normal anatomy. And you can see the physes have still not fused. The bone is white, completely white. It should not be like that. There is no cortico-medullary differentiation. The cortices and the medulla are one. It looks like a marble, and the fracture is like you have broken a marble slate. So this is called a marble bone disease, and it is inherited disease, and it is very difficult to treat, and the bones are not very uh, good at healing, and these bones are extremely hard and brittle. So you should know somewhat what is normal, what is abnormal. Then you can catch hold of a lot of metabolic problems. If you don't look at the X-rays normally, if you take this patient without planning and knowing what you will expect, then you are planning to fail. So failing to plan is planning to fail. So in this patient, we went inside with plates, and a lot of sharp drill bits are required for such patients because the bone is extremely hard and there is a risk of fracturing or breaking rather of the drills. So it is very important to be prepared when you take the patient for an operation. Another patient, this is the most common case which you will encounter in your practice. This is a female, a 65-year-old lady with both knees x-ray standing view. So we always order standing x-rays in AP view so that we can know exactly how much loading causes the reduction in joint space. You can see there is some varus in the knee. The knee is like bow legs, and there is grade 4 osteoarthritis. The bone is touching the bone on both the sides. A lateral view, you can see some loose body in the suprapatellar pouch, and the patella and the femur are also rubbing each other, so indicating a tricompartmental osteoarthritis of the knee joint, grade 4. So we did a total knee replacement on both sides, and this was done using robotics. Patient started walking the same day to achieve a very good result and movement. And you can see the alignment is completely straight now after the surgery. So this is an interesting case of polydactyly. You can see such patients a lot, and this is a congenital problem. Some families have it genetic. So you can see that there are two thumbs. This patient came to us because he was not able to wear normal footwear, and he was getting constant pain and ulcers around the toe. So we removed the medial most thumb and made it a one thumb, and now the patient is doing well. Another case where you can see this is the X-ray of the hip joint. Now, because you know the normal, you can see that these things are not normal. This is abnormal. There are some small calcified bodies in the hip joint. MRI showed again hyper intense imaging, which suggests of synovial chondromatosis of the hip joint. When we took the patient for operation, we could take out so many loose bodies. So these are chondromial. This is a synovial chondromatosis of the hip joint, and he was operated with total hip replacement. Now this is a case of deformity of the knee. You can see this is a hip, knee, ankle AP X-ray. So this is a long leg, full length X-ray of the lower limbs. This is usually done to see deformities and plan the surgery. So you can see this line, the mechanical axis is lying on the outside of the knee, which normally should be in the center. So suggesting that it is a case of valgus knees, or you can say knock knees. So because this patient had open physis, we did something called as hemiepiphysiodesis, where what we do is we fix the medial growth plate with small plates called 8 plates, which restrict the growth on the inside so that the knee can grow the growth plate out from the outside, and this in turn corrects the deformity. Once we achieve a full correction, this has to be removed. Sometimes patients just forget about these and don't come to us, and then in those cases we get a reverse deformity. So now, because the patient did not come, he may come with no, instead of knock knees, he may come to us with bow legs. So it is very important to have these patients come back to you for follow up regularly. So this is another case of traumatic deformity. This patient was operated elsewhere where the fracture was not fixed adequately, and as a result his fracture malunited and he had a varus knee which was extremely painful. So we did a deformity correction using 3D printing. You can see that this his bone anatomy has been 3D printed using a software, and a 3D printer where we could plan his case, make a jig, so that in the surgery it was easy to just put a jig, make these cuts, correct the deformity, and come out without more blood loss and avoiding extensive time in the surgery. Next modality we will talk briefly about is a CT scan. So, what is a CT scan? It is short form for computed tomography. So, it has the following components. There is an X-ray source, and the patient lies here. Then there is a plate which detects the rays, collects them, and form an image which can be processed on a computer. And nowadays we can make 3D images or reconstruction, and using some softwares plan the case, and it is very good for training as well. So what are the uses? The uses is it is used in trauma, accident cases. Then it is also used in cases of tumors to find out what sort of a tumor it is, if there is calcification, and also in complex deformity cases. So what is the difference between CT scan and X-ray? So CT scan is extremely important in intra-articular fractures because it gives us a good image and tells us about the fracture morphology so that we can plan the case. It has excellent contrast resolution. It obtains transaxial images, 3D reconstruction is possible, pre-operative planning is possible, and it is very good to teach your colleague, your juniors, and to our trainees so that they can know exactly the anatomy, the pathology, and how to fix that. The only disadvantage is that there is radiation. So you should be very careful, and the CT scan therefore cannot be advised in pregnant ladies, and it should not be extensively used in children. Other imaging modalities which we come across are arthrogram, angiogram, ultrasound, and scintigraphy radionuclide bone scan. So you can see this is a blood vessel which is supplying a tumor, and there is some new angiogenesis. So angiogram will tell you exactly how much the tumor is getting feeded and where from, so that you can do something called as embolization, where you send an embolus to a vessel which cuts down the supply to this tumor, and hence these tumor cells will die because they don't get adequate oxygen. And this is a bone scan. Typically bone scan is usually three phasic. So one is the loading phase, maintenance phase, and the late phase, where we can get an idea about other many pathologies, tumors, infection, inflammation going on in the body. So next modality we are talking about is ultrasound, which is very useful in many pathologies in orthopedics. It is rarely used though, and not used very often because it is operator dependent. So if you have a good ultrasonist whom you trust, you talk to them, you tell them what you are looking for, and usually they give you a good report. What are the advantages? It is an inexpensive modality, allows comparison with the opposite side, and there is no radiation. It can be performed at the bedside of the patient. It is non-invasive and gives you immediate, uh, reading and the report. So this is a short video where you can see the ultrasound of the shoulder, how it is done. So I hope you understood how an ultrasound of the shoulder is done. Next, we are going to see how to read an MRI of the knee joint. So typically, the most commonly two type of imaging is done in an MRI. One is a T2 weighted image, and the other is a T1 weighted image. So T1 weighted image, the fat and the bone marrow is looks white, and the ligaments cartilage look black. In T2 image, the ligaments, cartilage, fluid, they appear white and bone marrow appears black. So in short, T1 image usually is done to see anatomy and T2 image is usually to see the pathology. That is the normal rule. So look for the side. Which side MRI are you looking at? Sometimes the patient get two MRIs. So you should know which MRI you are looking at. Look at the patella. That is the anterior aspect of the knee. Look at the fibula. That is the lateral and the posterior aspect of the knee. And look for black in white and white in black. So if you go systematically, you can read an MRI of any part and find out what's happening. You should not only rely on the reports given by the radiologist, because sometimes they also miss some things and sometimes the reports are given by technicians. So you should not only rely on the reports and plan your treatment or a surgery. So this is something called as a pilot film. If you see an MRI on top, there will be a pilot films where you can see these lines and they will be marking from 1, 2, 3 like that. So this shows us where the cut is taken and what you are seeing. So you should not randomly keep on seeing things. You should know, so okay, I'm looking at the fifth image. So go to the fifth image and see what you can see. So you correlate where you are and you see exactly what you want to see. So again, if you see at the coronal and section from front to back, what will you see? You will see a patella. You will see the anterior horns of both the menisci. You will see the body of both menisci and collateral ligaments, the intercondylar notch with both the cruciate ligaments, and you will also see the posterior horn of the meniscus. So see this. This is a coronal view. You can see the femur, the tibia. This is the lateral aspect where there will be fibula. Then this is the vastus medialis muscle. This is the vastus lateralis muscle. This is the iliotibial band, the anterior cruciate ligament, the medial meniscus, the tibial collateral ligament, and henceforth. On the sagittal section, from medial to lateral, you will see fibula, lateral collateral ligament, body of the lateral meniscus, horns of the lateral meniscus, notch with ACL, notch with PCL, horns of medial meniscus, body of the medial meniscus, and the medial collateral ligament. So, if you know systematically what to look for, you will not miss out on anything. So this is an example. This is a sagittal view of the knee, the lateral aspect of the femur, the kneecap, the tibia. You can see this is the PCL. Then there is a patellar tendon, medial anterior horn of medial meniscus, the posterior horn, and you can also see the popliteal vein, the popliteal artery, and the muscles of this area. Then you can see if you know exactly which image you are looking at and what the anatomy is, then you can easily find out what the pathology there is. So on a T2 image, if you see a hyperintensity, then you know that there is some tear or a sprain and you can treat the patient accordingly. So just to tell you what the normal ACL looks like, you can see the normal ACL is looking very taut. It is going from the posterior part of the femur and coming and attaching on the medial aspect of the tibia. And a torn ACL looks something like this. It has bulked, it has become wavy, and it is not as taut, and it is not clear in its dimensions. So you can safely say that there is tear of the anterior cruciate ligament. So again, how a PCL looks like? A PCL looks like this, attaching to the posterior aspect of the tibia and then going on and attaching to the femur on top. And a PCL looks like this. There is a loss of this smooth contour and it becomes wavy. And you can see there is a lot of signal change around the PCL, which suggests that there is bleeding and hence a tear. This image shows a tear in the posterior horn of medial meniscus, which is going from the articular surface to up to the root, and this signifies a tear. And you need to see other sections to rule out if it is a bucket handle tear or if it is causing a trouble in the joint, which may need to be repaired or excised. So how does cartilage look on an MRI? You can see this is the bone, and on top of the bone there is this lining. So you can see there is good thick cartilage on the back of the knee, and as you come forward it becomes thinned out, and in this area it is absolutely thin, suggesting a damage to the cartilage in the distal femur of the medial femoral condyle. And you can also see a torn meniscus in the posterior horn. Next, we are going to talk a little bit about the shoulder MRI. So again, there are three type of cuts: coronal cuts, sagittal cuts, and axial cuts. On a coronal cut, you see the supraspinatus muscle going from posterior to the anterior. Sagittal oblique, it's perpendicular to the supraspinatal muscle, and axial are again cross sections of the shoulder from top to bottom. So again, look at your palette images and know where you are looking at. So an example of a coronal image where you can see the humeral head, the IGHL, the greater tuberosity, the infraspinatus tendon, and the infraspinatus muscle, which goes on to become a tendon and at the end getting attached at the tuberosity. In a sagittal view, you need to know what is anterior and what is posterior. So this is the deltoid, this is the acromion, this is the teres minor, this is the deltoid of the posterior aspect and the anterior aspect, and there is biceps. So biceps is like a light house of the shoulder. If you're lost, you look for the biceps and then you know where you are. Next, the axial section again, there you can see the labrum, anterior labrum, the posterior labrum, the humeral head, the biceps groove, the biceps tendon in the groove. If you should know if the biceps tendon is slipping, snapping out of the groove, or if there is a tear in the labrum called the Bankard lesion, and if it is associated with a fracture of the anterior glenoid rim, then it is called a bony Bankard's lesion. So labrum, as we saw, is best seen on an axial plane. It appears on the anterior and the posterior rim, and it is triangle shaped. And tears detachment tells us, shows us the fluid signal intensity, which we can suspect a tear. Again, this is a schematic diagram showing the glenoid with attached labrum and also attachment of the biceps, which come down along the groove. So the most common pathologies seen in shoulder cases, which you will come across 80 to 90% cases, will be either stiff shoulder, that is frozen shoulder, or you will see rotator cuff tears or Bankard tears. So you should know the anatomy of the rotator cuff. Rotator cuff muscle is formed of four muscles, that is the subscapularis, supraspinatus, infraspinatus, and teres minor. So you should know this in order to find out which muscle is torn so that they can be treated accordingly. So this is a section where you can see this is the acromion, supraspinatus fossa, where there will be supraspinatus, then this is the clavicle, this is the infraspinatus, and this is the subscapularis. This is the teres minor. So the rotator cuff tendon has different parts. Critical zone is called, where it is 1 to 1.5 centimeters from the enthesis, and it is a hypovascular zone. So the importance is that this is very prone for degeneration. So patients who are old will have tears of the tendon in this region. If there is injury of the tendon in the musculotendinous junction, then it is usually traumatic. So the type of tear and the location of tear will tell you where the tear is and why, what is the mechanism, so that you can treat it accordingly. So you must have also heard of a term called tendinosis. So tendinosis is usually just an inflammation of the tendon and nothing else. But if it is not treated well in time, then this tendinosis may become a tear if it is not given adequate rest and not healed well. Tears can be partial or full thickness. A partial tear can again be either on the side of the joint called the articular side tear, or an interstitial tear in the substance, or a bursal sided tear, that is the tear in the subacromial space. Other pathologies which you can see, which can exist concomitantly or differently, are intraosseous cysts. So they are nothing but fluid filled cavities, and you should be very alert and alarmed when you see this, because if you are dealing with a rotator cuff tear, when you are going in to repair this tear using a screw or an anchor, then if you put this screw in a weak side of like this, then there are high chances of failure. So you need to know where you are going to put your anchor, so that you don't fail in your surgery and you give a patient a good result. Another common pathology which you see in shoulder is calcific tendinitis. So you can see these are extremely painful, and sometimes they need excision, sometimes people do needling, sometimes injection, but usually in recurrent cases you need to remove this calcific tendinitis. It's extremely painful and it's like a chalky white material which deposited there. So how does a full thickness rotator cuff tear look like? It shows high signal on T2 weighted image. This is a direct sign showing full thickness tear. You see the tendon discontinuity. It can either be at the enthesis or the muscular tendinous junction. Then there could be retraction. You should know where the retraction is. Is it just lying at the level of the tuberosity, or it has crossed the coracoid? So this will help you plan your treatment, whether it is repairable or not repairable. Then you also look at the subacromial bursa, subdeltoid bursa, and also look for muscle atrophy. So you have to measure the retraction of the tendon in centimeters. Okay, and then from there you can plan your treatment. So suppose the patient is coming to you and the tendon is not much retracted, then it is easy to just put there and fix it with anchors. But it is, if it is extremely retracted, you may have to alter your plan and either go for a reverse shoulder arthroplasty when the rotator cuff is not repairable, or you can also use pitch patches, which has now recently come in, and you can get away by just putting a pitch patch and some PRP in that area to avoid any arthroplasty in such cases. So another thing which you should know about is to find out if you do a surgery on a patient, will the patient have a good result or not. So to prognosticate the case, there is something called as Goutilier's classification, where you look for muscle atrophy. So you see this is the acromion, and if you make a line, and if the muscle is lying on top of this line, then it is a good muscle bulk. Patient will have good recovery, and if it is just online, maybe have some good recovery, but if it is below this line, then the patient is having more of fat than muscle, and probably the muscle has atrophied, and the patient might not have a good result even after having a surgery. So yeah, so this exactly shows you more fat than muscle, which gives us a poor prognosis of such patients. So I have already spoken about Bankard lesion. When there is a tear in the anterior inferior labrum, this is called a Bankard lesion. And if there is associated fracture of the bone of the anterior glenoid rim, then it is a bony Bankard lesion. You can see this is a bony Bankard lesion. There is a broken piece of bone on the anterior glenoid. Now, briefly talking about the MRI of the lumbar spine. So, what happens? How do you read a spine MRI? First of all, you should have good indication to do an MRI of the spine. When do we order a spine MRI? You can just get away with X-ray, but for MRI spine, patient be having persistent low backache or sciatica, suspected disc herniation, spinal stenosis or degenerative changes, patient with trauma or injury to the lower spine, with neurological symptoms, numbness, weakness, or radiating pain, if you are suspecting any chronic infections or spinal tumors, or if you are going to do a surgery for a patient planned for spine surgery, you should have a recent MRI of the spine. So again, T1 weighted images, T2 weighted images, inversion recovery IR, and post contrast. So in cases of infection, you may do a contrast MRI to have a better picture of the case and to plan it better, treat it better. Other advanced sequences not available everywhere are DWI, SWI, multi-point Dixon, and dynamic, which are not usually available in most of the centers. So again, CSF will look black on T1, CSF will look white on T2. In T1 contrast, the CSF looks black, but the blood vessels will look white. Stir sequence, DWI and ADC again are not available in most of the centers, so we'll not discuss about them. So this is a T1 weighted image. You can see the CSF is black, completely black. You can see some degeneration in the L5 and S1 region with the reduction in joint space. Then this is a T2 image where the CSF have become white, but the bone on the lumbar spine, this one has also been white. And this is a stir special imaging where you can again see that the CSF is white and the bones have become black. So again, you should know anatomy before you can comment on the pathology. So what do you have to count the lumbar spine which you are talking about. So count from below or from top. So S1, L5, L4, L3, L2, L1. And then in between that there is an intervertebral disc and then there is a spine with CSF. So you should be able to see all these structures, the bone on the back, there will be muscles. This is the sagittal view. So once you know the anatomy, you can find out what is the problem in the MRI. And if you see this MRI, the curve of the spine is gone. There is a lot of degeneration in between the bones, lot of destruction. The lumbar canal is attenuated. The spinal canal is narrow. The nerve is getting compressed and you cannot see clearly the CSF flowing in the spine. So this is a case of disc degeneration and degenerative disc disease. This patient is suspected to have chronic backache with limited mobility. So the most common case in lumbar spine, which you will see young patients having disc herniation, they will say, "Doctor साहब sciatica हो रहा है, मेरे disc बाहर आ गई है." So what is this disc? So this is an axial view which shows you the body of the spine, and you can see that this is the disc, the black color disc, which is protruding out on the left side and compressing the canal on the left side. So this patient on a sagittal view, you can see that this is coming out and pressing the nerve on the left side. So that this patient will have sciatica symptoms on the legs in the left side. So the operation will relieve the patient's symptoms and relieve this nerve so that his radicular symptoms are gone. This another condition called as spondylolisthesis. What happens in spondylolisthesis is one bone slips on top of the other bone. So once this bone is coming in front, you will see that this nerve is getting impinged on the back, and the patient will have severe backache and with along with radicular symptoms. So such patients have to bend forward in order to reduce the pain so that the canal is jacked up or open. And this is also called as a shopping cart sign, where you can see people walk on a shopping cart with their arms rested on the shopping cart bending forward, and this typically relieves their symptoms. So you should know these simple pathologies in order to catch the diagnosis and treat the patients accordingly. A short video showing lumbar spine, how to read a MRI of the lumbar spine. So I hope this made a lot of queries cleared. This was a very good video showing how you should go about reading a lumbar spine MRI. So other abnormalities or pathologies which you look and see on an MRI of spine are spinal tumors. So this is a spinal tumor in the, you can see that it is in the dura, which is communicating and pressing on the bone. Then the symptoms, what sort of symptoms will the patient present with, which may include back pain, neurological symptoms, compression symptoms, and spinal tumors can usually be primary or it can be a result of metastasis when the tumor somewhere else in the body has spread to all areas of the or different parts of the body. So the treatment of spinal tumors involves a multidisciplinary approach including sometimes a surgery, a radiation, chemotherapy, or a combination of all these. Other cases which you commonly see and in Indian subcontinent is tuberculosis. Other infections like bacterial, fungal are also there, but most common is the tuberculosis of the spine, also called that the spot spine. So how will you see? You can see the image. The bony destruction is massive with a lot of pus pressing the nerve on the back and the front. Sometimes there is a Schwarz abscess on the anterior aspect, and if you see the axial view, the bone is completely destroyed. It is pressing the nerve. Sometimes you don't even see the nerve in the canal. And usually these patients, if caught well in time, we need to prevent any damage of the musculature or the bones. We have to correct the alignment, give them some support, some nutrition, then start them with ATT once the diagnosis is achieved, and then monitor their progress about the treatment, if the medicines are working or not working, whether they need a dose adjustment, or in worse cases, sometimes surgery to drain the pus and fix the weak bones. So you have to keep the patient in follow up, and usually a case of port spine goes on to get treated ATT is given for a period of 12 to 18 months, depending on the response of the patient. Other infections, which most common, are pyogenic infections, that is bacterial infections. The patient has high grade fever, backache, neurological symptoms, and where port spine is slow progressing, the pyogenic infections are fast progressing and they need immediate treatment because they're extremely painful and the patient worsen very fast. So we come to a concluding slide. I would like to say that clinical examination is still the key to clinch the diagnosis and treat the patient. It should not never be that you see the imaging first and then talk to the patient. It should be the other way around always. Talk to the patient, take a history, do the examination of the patient systematically, then go for the imaging. And the imaging is usually just to confirm the diagnosis and plan your treatment, what other treatment options you can give to the patient. And you should use these modalities judiciously. Like CT scan has high radiation, do not order it for all the patients. It should only be done if it is extremely necessary for your plan of treatment, and never do it on pregnant ladies, or judiciously use it for kids, and know when to stop. Like I've seen people who order all the images, all the modalities which are available to them. They will also get an ultrasound of the shoulder, CT scan, MRI of the shoulder, but sometimes they don't do a basic X-ray, which is the most important thing to identify a problem such as a fracture. So go step by step and don't be in a hurry to order images, because sometimes these a lot of information also confuses you and deviates your path from treating a patient judiciously. And this is a continuous learning process. Your peer community is there to help you. We are all there to help you. And if you think that you cannot do good to the patient, you cannot help the patient, it is a good practice to refer the patient to a specialist. There is no shame in saying, I don't treat such patients and I am very happy to help you, send you to a right person who can help you better and help faster. The patient will be happy and patient will always remember you, that you send the patient to the right place. So there is no shame in saying that I don't know. Nobody can know everything. Everybody is a specialist in their own field. And I think it's a peer community and continuous learning, which is the most important thing. Thank you, Dr. Parijat. I am thankful for this opportunity, and I am very happy to take any questions which might have arisen from this lecture.